All right, good afternoon, everyone. Thank you again for joining us. We'll be starting here at about 1:02. We're just going to give time for all the participants to join in. If you feel free, just jump in the chat box and let us know where you're from. There's nowhere to go. Oh, no, you made a choice. Now it's up to me to follow out gracefully. Know you hold the key, baby. Whenever you call me, I'll be there. Whenever you want me, I'll be there. Whenever you need me, I'll be there. I'll be Okay, so you have people from Denver, Indianapolis, Dyersburg, Tennessee, Greensboro, North Carolina, Springfield, Illinois. Thank you all so much for joining us. Happy Friday. I see a lot of familiar names. Thank you all for tuning in with us week after week. Good afternoon. Thank you all for joining us this afternoon. We will be starting in a couple of minutes.
fight. And they see a young couple having a time at school. And the Eagles want to test the brother's man. So they came and tested me because of my heritage. And the loud bright colors that I wear. I wasn't talking because I'm a fashion misfit. And the outfit that I'm wearing, brothers dissing. Well, I stay calm and pray that they need me. But they switch the parts of my dates and anatomy. Why, Lord, the brothers have to drill me? Because if I stop and hit this man, they'll have to kill me. You see, everyday people. Yeah, yeah, yeah. See, everyday people. I told them, please let us class first. I said, please, because I don't like killing Africans. But stop, and I ain't like.
Good morning, everyone, and thank you for joining us again. My name is Damon Johnson. I'm the program manager for Georgia AIDS Education and Training Center. I have my team with me, Marcella Ryan Harris, Evan Pitts, and Dr. Austin Chan. We look forward to a very dynamic discussion with you all today. And again, this is a community forum, so please feel free throughout the session to drop your names, your email, or any questions, comments, and/or concerns that you have in the chat box. We have a very dynamic panel friends that we work with on the regular. We have Mr. Larry Scott Walker, who you'll hear more about shortly, who will be the moderator for this call. And we have Mr. James Sacco, one of our trusted consultants that always adds flavor and flair to any of our presentations. So without further ado, I'll pass the mic over to Larry Scott Walker. And please remember to stay engaged with the chat box, and we look forward to this presentation today. Thanks, guys.
Thank you so much, Damien. Thank you so much. And thank you all for attending today's conversation. It is a pleasure to grace you again. As Damon pointed out, I'm Larry Scott Walker. I'm the Executive Director and co-founder of Thrive Support Services. And we are here for Stronger Together, the Reload. It's been 2 months since we've been talking about and dealing with the coronavirus, and since we first began to engage you around the coronavirus, and we want to bring some new information. We would like to thank Thera Technologies for sponsoring this space and helping us to provide this information for you all. Don't forget, before you leave at checkout today, to fill out your evaluation and enter to win a $50 gift card from Amazon. You can share it with me once you win it. As well, the slides will be recorded and will be sent out on Tuesday, June 16th. We want to take a moment before we start everything to honor the struggles that are going on in the streets within our Black and Brown communities. We stand in solidarity with our Black family. Many of us are Black, and we feel this within our bones, within our DNA. So we want to take a moment of silence for those who have lost their lives to police brutality and anti-Blackness. Thank you all so much. Today's agenda will go as such. We will have a medical update from Dr. Chan, which will also include a fact versus fiction section to get out all of those things, those crazy things that we've been hearing in community. And then we will hear from Jim Sacco, who will come with and give us a social and mental update and check-in. And then I will bring you an update as to how to engage in the safest ways possible the reopening of your towns and local jurisdictions. And then as well as a sexual health update. I know a lot of people want to just bump the sexual health update to the front, but we will be coming up with because some new things have even arisen around sexual health and the Department of Health and Human Services guidelines. So stick around, and we definitely want to hear your feedback. Your feedback is what fuels us to continue to do this. So please engage us within the chat box as well as the Q&A. This quote is one of the quote that pretty much guides us, and we like to remind every audience and every participant that our shared vulnerability to this virus is our solidarity, our source of solidarity. We must remember that the virus, not people with COVID-19, or affected by it is the enemy. And that's from Valerie Earnshaw. The next presenter, I will get my notes. First, we'll hear from Dr. Austin Chan. Dr. Chan is an assistant professor at Morehouse School of Medicine, as well as the principal investigator for Georgia's chapter of CTEC. He graduated from Emory University, where he also completed his internal medicine residency. He's a trained Duke University infectious disease fellow, where he specialized in clinical pharmacology and early phase clinical trials. His clinical and research interests are HIV and Hep C co-infection, as well as access to care. Without further ado, Dr. Austin Chan. Thank you.
Thank you so much, Larry, for hosting. And of course, thank you to Thera for sponsoring us. It was a wonderful moment of remembrance. And I really love that quote. One thing that I'll say is that I've seen a lot of, people and families turn on the first person who tests positive for COVID-19. And I think that's exactly the wrong response. Just because you're the first person to test positive doesn't mean that you were the first person in your cluster of people to actually contract the disease. And so, again, I want to reduce stigma. I know it's hard because there's a lot of blame to go around in these sorts of situations, but I really want to resist that kind of thought process and encourage, responsible testing and safety and appropriate social isolation. All right, I'll keep it at a crisp 15, and then I'll hand it over to Jim. So let's take it to the next slide. So, this is a pretty common one that we shared a couple times before in our presentation. Allergies are kind of fading away a little bit. Spring is kind of moving away. Pollen season, depending on where you are, is kind of ending. Certainly in the South, it is at least. And so I just want to emphasize that at this point in the United States, perhaps you're listening internationally, but in the United States is moving into summer. And with the warmer weather, I would consider any symptoms to go ahead and what should prompt you to go ahead and get tested. If you have fever, dry cough, shortness of breath, anything like that, certainly myalgias, even diarrhea, and some rhinorrhea, some runny nose. I think any of these symptoms should go ahead and prompt you to get testing. Certainly the testing situation differs state to state and even county to county, but if you have it available, go ahead and do it. If you have a question in your mind, go ahead and get tested. I think we should err on the side of over testing to do our due diligence and help stop the spread of the virus. So I know that, I think you do have to ask yourself, everyone knows their own body best. And so I think that if you truly feel like these are your allergy symptoms, you always get allergies around this time of year and it's a specific kind of pollen or some other, allergen that affects you, that's okay. Take a break. But if there's any question in your mind, go ahead and get tested. Next slide. So, with respect to the testing, again, most of the sites are working on like a call ahead with a little bit of a quick screener. Georgia, I know that Fulton and DeKalb, we have asymptomatic testing, which is really great. I think that's kind of that would be my preferred method, nationwide, but I think we do have to build up to that capacity. Hopefully we'll continue to expand and get better with that. What we are seeing is that you don't have to do the deep swab all the way to the back of the nose anymore. There's some good data to suggest that just up to the middle of the nose is okay. So that's called the mid-turbinate test as opposed to the nasopharyngeal where it goes all the way to the back. So hopefully where you're getting screened, they're doing the mid-turbinate. It is a little uncomfortable, but for the common good, it's for the greater good. So, go ahead and get tested. Next slide, please. And so here's the question, when should I go to the hospital? This is always a tricky one. And so what I would say is same guidance as before. If you're feeling short of breath, if you feel, suddenly very, very sick with really bad malaise, if you have certainly chest pain, for sure, that should prompt you to go. If you see a loved one is newly confused or has any bluish tinge on their lips and face, I would definitely prompt that person to go. The other thing, I've actually found that pulse oximeters are pretty widely available, and it's very helpful over the phone if you can, get someone your pulse ox reading. It's usually just a little device that goes on the tip of your finger, gives you a number 0 to 100. Obviously, in the high 90s, 95 to 100 is good. A little lower than that, I would certainly keep a log. But that's something in addition to fever screening that can help with detection of the virus if a test isn't available. The other thing that I'll add is if you're recovering from COVID-19, we have seen a lot of pulmonary embolism or embolic events after infection, after you've recovered from infection. And so, most hospitals are now putting people on an anticoagulation protocol. But if you feel acutely short of breath after you feel like you've already recovered from COVID-19, I would go ahead and seek care because this could represent, a clotting event. And so that's something to keep in mind. Dr. Fauci the other day said, compared to, he was speaking from a pathophysiology perspective, but the quote was essentially, compared to HIV, this is the most complicated infectious disease process that I've had to face in my lifetime. And, while HIV is a devastating epidemic, we have spent so much time with it now that we understand its pathogenesis. And we, unfortunately, are just barely scratching the surface of what COVID-19 does, and what long-term sequelae of infection mean, and also how infection evolves in individual people. So it's a very complicated illness. Next slide. So I wanted to spend some time talking about specific behaviors. There's actually been a lot of really good articles about this. NPR had a couple. I think Vox had another one. But I want to go through specific behaviors and discuss why they're high risk so that you can use this information to apply it to your daily life and, calibrate your own personal risk. So I would say, the highest risk behaviors involve prolonged indoor exposure. So I would say that either flying on an airplane or being on a cruise are the single highest risk activities that you could undertake. Now, why is this the case? Number one, you are an extended period of time in an indoor setting with poor air circulation. Number two, you're in very close quarters with people, even if Delta and other flight carriers are having individual spacing, like leaving the middle seat empty. You're still in a confined space. That's definitely not 6 feet, and you cannot further socially distance from people even if you wanted to. Like if you wanted to move away from that person, you couldn't do anything about it. Next, you just have a lot of unknown contacts that you have no idea what their exposure situation is or their testing history. I think some airlines are putting in specific protocols and all, but at the end of the day, you're basically flying. You have all these encounters through the airport, and then of course you have all those encounters on the airplane itself where you just can't physically social distance from folks. So that would be, I think there are certainly reasons to fly if you have to. One of my uncles has to get care at Brigham and Women's, for his throat cancer, and he lives in Atlanta. So, he's like gearing up, trying to find the appropriate PPE to make the flight or potentially drive. But I totally understand that there are scenarios in which you have to fly or there's no other option. And, I think the best thing you can do is be as safe as possible, wear eye protection, wear at least a droplet barrier surgical mask if you can, and just try to, practice proper hand hygiene throughout. Next slide. So on the other end of the spectrum, camping in the woods, I really like the outdoors. It's kind of like a newer thing for me. But this would probably be like the lowest risk thing you could undertake. So outdoors, the droplet dispersal is very, very broad. You have tons of air circulation. A breeze rolls through, and all of a sudden, it pretty much would clear out any viral particles that are clearing up or accumulating in the air. There's very few people around, and even if there are a bunch of people around, you can just make sure you maintain an appropriate distance from them. If you wanted to go camping with like another family that you trusted, or you wanted to go camping with like a small group of friends, it's totally reasonable. This is a good activity. I think that hopefully we do see a little bit of a resurgence in outdoor activities during this outbreak in the summer. So, take advantage of the nice weather while you can. Next slide. So this one is this last one I wanted to bring up because it's kind of a medium risk scenario. And depending on, your specific behavior and how you choose to mitigate risk, this can either be a high risk scenario or, a low risk scenario. So this is a backyard cookout. I think it's a pretty common thing. I certainly love grilling myself. But, summertime in Georgia, lots of people just on their porches with their grills, having a lot of people over, making hot dogs, burgers, chicken, ribs, etc. And so, if there's a large crowd at this barbecue and there's not a lot of room to maneuver, or it's on like a porch where there's not a lot of space to get away from other folks, that could maybe be a little bit risky. And so, in general, most of these things take place outside, but obviously it's kind of hot. So sometimes people go inside, and certainly people concentrate in the bathroom. So that may be a potential like risk area there. And of course, as people get more comfortable in a specific setting over time, they may become more lax with their individual PPE, like, lower the mask or something, or make sure, they just happen to forget to be 6 feet away when they're like eating or, talking to other folks. And so, you can really mitigate this risk. Obviously, everyone should be masked, outside if they can for as much as they can tolerate, or if not, they should stay 6 feet away from other folks. If you go inside, I would encourage, universal masks inside, and just really be cognizant of your hand hygiene, wash your hands often. And then, of course, if you're able to test everybody with reasonable time beforehand, then I think everyone should feel, relatively safe. If every one person, every household has a negative test, I think you can feel pretty safe about getting together there. And so obviously the highest risk behaviors you could do at a cookout, if you share food or you share drink with somebody who's not in your general cluster, that's obviously the highest risk. And, again, just prolonged indoor exposure without a mask is going to be your biggest risk. Next slide. So, the hydroxychloroquine issue rages on. I think last time we presented the data out of China saying that there was no particular benefit. Since that time, there were 2 studies that came out by Dr. Mehra and Dr. Desai that said that there was actual, increased adverse events, but then there were a lot of questions about the data. And so these studies were retracted. And so, I think it was honestly is kind of a huge scandal in the scientific community. And I certainly agree that this was gross scientific misconduct on the part of the authors and very dishonest. And, it caused a great deal of harm because a lot of countries, including WHO, and I believe NIH, briefly halted their trials because of this data. And so I just want to get specific, though, about hydroxychloroquine, because I know there's a lot of information floating out there. Essentially, they found that in the laboratory that hydroxychloroquine potentially could inhibit, viral replication of COVID-19. That was very interesting. And so the next step then would be to do human studies. Well, hydroxychloroquine, as we know, is used to treat a host of other conditions, including lupus and other stuff. So it has a really good safety profile. So we know it's relatively safe. It's not perfect, as we see with the cardiac issues. And, it has some in vitro activity. But that doesn't mean that it actually can treat COVID-19. And that's why we need to ask that question, and we need to do the appropriate study. And so, it's kind of a weird spot because it is on the market and you can take it. But most hospitals that I know are restricting hydroxychloroquine for COVID-19 use only under clinical trial conditions, meaning that you've enrolled in a particular study like the NIH or the WHO study, and you're receiving the drug as a participant in that trial. They're not doing the off-label use, because I'll also say again, it does not have FDA approval for treatment of COVID-19. It could work. I'm not saying it can't, but we just don't know yet. We just don't have the information. And why use this when you have this other drug that does work? Next slide. So remdesivir, here is an antiviral that was designed to be an antiviral that, we have good data. We did the multi-center, randomized control trial and has proven to be very effective. We were a site at Grady for the remdesivir was out of control, and I personally was fighting very hard to get my patients on this because, in my heuristic individual experience, it dramatically improved outcomes. I saw people come off oxygen almost immediately who were sitting on 4, 5, 6 liters, almost possibly getting intubated. And so in my mind, if I could only get one drug for this, I would run remdesivir. This is what I would give my mom. This is what I'd give my family. Next slide, please. So just wanted to quickly go over the The demographics, it's a little small. I just wanted to show you that they did a good job with the study. It was very well designed, randomized, controlled. They eventually unblinded it because the remdesivir arm was doing so well, but it is truly compared to placebo. So some people got drug, some people did not, and the people who did get the drug clearly showed benefit, as shown on this next slide. Sorry, next slide, please. Yeah, there we go. So here we see the survival curves for different categories of patients. The blue line is remdesivir. Y-axis is survival. So higher is better here, and it's survival per days, percent recovered. And so you do see a faster recovery and overall improved mortality with remdesivir. And specifically, it's most pronounced in patients receiving oxygen. That's going to be box C, bottom left. But also, it did show some benefit in patients not receiving oxygen. And I think that the biggest issue with remdesivir is going to be drug supply. They're scaling up. They should have millions and millions of doses coming up soon. But how do you distribute that worldwide? I don't know what the results of the favipiravir studies are yet, which was another potential treatment. And so right now, remdesivir is the only drug that has been proven to reduce mortality from COVID-19. Now, it does have its problems. There's no question. It's got some liver toxicity issues. They didn't give it with Tylenol in the study. I think we're going to learn more about its safety profile, which overall was good, but, there are still some things out there. And so definitely something to keep in mind. But the good news is we do have something. We do have something. And there's lots of other medications that are on the horizon. Next slide. Sorry, I got to speed this up. It took too long. So just a couple things here. Does warm weather affect viral spread? And this is kind of the biggest debate, the biggest question. Is this thing going to go away in the summer? Well, there are some factors to suggest this, and I encourage you to read Harvard T.H. Chan School of Public Health. They have a great discussion about this. But essentially, there are environmental factors that do affect viral spread. So we know that COVID-19 is transmitted in water droplets. It's droplet-based transmission. Well, colder air is going to be less humid, so with less water in the air. And as the air is drier, then it increases. So the particles themselves that come out of your mouth get smaller and then stay in the air longer. So it's suspended longer and it's going to be more infectious. Now, human behavior. People spend more time indoors when it's cold outside. During the summer, everyone's playing outside, doing outside things, hopefully having outdoor cookouts and camping, as I suggested. But indoors, in the winter, everyone gets closer together. There's less ventilation. You don't want to open the windows indoors because it's so cold outside. You don't want to let the hot air out. So that kind of behavior would increase spread. And, last but not least, there are some host factors, with ourselves. With the drier air, we have decreased, mucus. We have inflamed nasal mucosa, nasal epithelia, potentially making us more susceptible. In addition to that, we're just sneezing and coughing more because exposure to the cold air can kind of prompt those reactions. In addition to that, you do have other circulating viruses that make you more susceptible, circulating seasonal flu, the other coronaviruses that cause the common cold. And so there's a lot of different reasons to suspect that, in the winter, there could be increased viral spread. It's not going away in the summer. I think as we see, you still have some viral spread going around, but in the winter, it's very likely that this could be more infectious. Next slide. So there was this theory I've seen floated around called viral attenuation, the idea that SARS-CoV-2 will, mutate into a form that is not as deadly. Unfortunately, this has just not been the case. Some of what makes the virus so infectious, it needs to ramp, it can't really change what it is because, the form in which it's taken has proven to be both spread rapidly and continue to circulate. And so if it mutates to become less deadly, then maybe it's not as infectious. And so when you look at other viral models, you look at other coronaviruses, other viruses in general, it's very rare to have a virus become less deadly over time. We're in a forum where we've often talked about HIV, hepatitis C. These viruses have been around for at least 30 years with no change in how deadly they are. We've seen that HIV virus is broken off in lots of different strains, but each of those can still result in end-stage immunocompromise. So I would say that this theory in general is not looking like it's going to be the case. Next slide. So last but not least, I'll run through these pretty quick, and of course, if you have any questions, I'll be available at the end. So asymptomatic carriers can spread COVID-19. I think this is a tough one. WHO just came out with a statement saying that, I mean, they were kind of 50-50 and then they walked it back. I think the short answer is, we don't really know. I would be concerned that there are spreaders who are asymptomatic. The initial case was the initial case, quote unquote, of asymptomatic spread was in a Berlin gentleman who had met with a Chinese businessman, and that was the one back in February that really freaked me out. I would say it's possible. I don't think we have as many asymptomatic carriers, as we're afraid of. I think it's probably around the reported 15 to 20%. But there's still some things we don't know about the virus, right? Like if I continue to test positive, if I've recovered from it for like 3-4 weeks, am I still infectious? It's not ethical to do that study, but also, we don't have a lot of answers to that question. So next, if the COVID-19 antibody test is negative, that means you don't have COVID-19. Well, unfortunately, that is not true. So antibodies take time to develop. As we know with HIV, it takes about like 6 weeks or so. And so you could be acutely infected with COVID-19, even if your antibody test is negative. And of course, there's tons of different antibody tests out there, so I encourage you to get the best one. Probably the Roche or the Abbott is probably the best. And last but not least, states who are seeing steady case counts means that coronavirus isn't an issue anymore. Well, unfortunately, this is just not the case. I just encourage you to still use caution. We may come into a lull period in the summer for all the reasons that we detailed before, but the reality is that this thing can still spread. It can definitely still spread indoors, and we need to take all the appropriate measures to distance and continue hand hygiene and good practices so we can keep each other safe. All right, sorry I ran over a bunch, but I'll pass it off to, I believe it's Jim going next.
Actually, thank you so much, Dr. Chan. That was an amazing wealth of information. We're going to take a 90-second break to give you like a minute to take like a bio break, to put any of your questions or comments into the chat or question boxes, and then we'll come back in here for Mr. Jim Sacco. Thank you, everyone.
Good afternoon, everyone. My name is Evan. We'd like for you to keep us up to date on your needs and interests by completing our training request survey. Let us know what training topics you'd like to hear by clicking. We look forward to hearing from you all. Thank you.
There. Welcome back from your bio break. I guess we all had a bio break. I'm Jim Sacco. I'm a consultant.
I'm sorry. Oh my gosh, I was reading your your bio on mute. I'm so sorry.
Oh, no worries. Tell
Go
me.
back.
What's the
Go
story?
back behind. Put back the curtain. Pull back down the curtain. Pull back down the curtain.
Okay. He's not here. He's not really here.
Sorry about that. I was on mute, everyone. Jim Sacco, licensed clinical social worker, is a consultant trainer based out of Asheville, North Carolina. His training expertise includes a wide range of social work, mental health topics, including communication skills, addiction, sexual health, case management, motivational interviewing. As a clinician, he has provided services in medical, substance abuse, and community-based counseling settings. His previous training clients include the World Health Organizations, the Centers for Disease Control and Prevention, Emory University, Duke University, and HIV organizations around the Southeast. Since 1986, he has provided training for more than 50,000 health care workers. Without further ado, Jim Sacco. Sorry about that technical blip.
It's all good, brother. It's all good. Welcome, everybody. Thank you. I'm so honored to be part of this. I want to start. I've got a lot of content. I want to take a deep breath in that 90-second pause. I know there are people who are struggling, and I guess in the chat box I've typed the question that I'd like us to start with. There are people that are, because of all we are going through, emotionally, physically, psychosocial, people we love. I really think it's important to take a minute and think about what you're doing to take care of yourself. So in the chat box, for those who are willing, if you'll drop down all participants, what's your go-to self-care? What are you doing to take care of yourself in this crazy time? Mitch is getting out there. Mary says, I better get better. Mary, they're coming with some suggestions for you. Everybody help Mary David out. She is not doing enough, and she's got to do more. What do you do to take care of yourself right now? Susie's out there running. You better get a little work in. Risa's also swimming. Irene, they're going to give you some suggestions. Here they come. Fasten your seatbelt. Ms. Coco Bell, I got gardening, exercise, meditation, self-reflection. Julie saying I limit how much social media. Some people say they limit how much news. Donna spinning. You go. Spinning is a tough thing. A lot of people exercise. You better pray, says my friend. Marco, we're going to talk about sex in half an hour. So stay tuned. You're going to hear about sex. I promise. All about sex. Lauren's walking dogs. Sex is coming. Virtual trivia with everybody. Doing virtual whatever. Exercise, prayer, virtual trivia. Love that. Anybody else? Your self-care strategies. I hear a lot of gardening, get outside, physical activity, go to the water. Again, keep those coming. We had several people say they are struggling and need got some fishing people. That's great. I'm going to go ahead and get started. Please keep meditation, baking, reinventing myself, Marco. Que bueno. All right. So why are we here? I'm my update is kind of what's new and what's not new. What's not new is the disproportionate impact of people of color. I wish I could say there was different news. There is not, continues to be an epidemic disproportionately affecting Black and brown people, health outcomes worse for people of color. There's the statistics there. There's an excellent JAMA editorial that happened, April 15th. Clyde Yancey is a cardiac surgeon at Northwestern, and he did this really searing article that the COVID's shining a light on social determinants of health is not acceptable. Just really, really well thought out. But there's the example again: disproportionate impact of race. Better after joining a Black Lives Matter march. Thank you, Mary. Next slide. So COVID factors. This is not so new. These are all the things that have been around. People with these cofactors. Most importantly, older age. 80% of people who've died have been over 65 or older. So all of these things tend to make complication. And again, age is probably the single most, but other chronic disease states certainly come into play. If you get COVID, you've got these underlying chronic health problems. Your likelihood, again, cardiovascular, hypertension in particular, much more likely to have more serious disease, and the risk of fatality seems much greater. Next slide. Again, I talked about outcomes earlier. This whole idea that there are black and white counties, you just kind of go, really? But of course we know that, but just the idea that we've looked, and the death rate in counties that are predominantly black versus predominantly white, sixfold higher. And the only difference, observable difference, is the racial profile of those counties. Next slide. I also think one of the things that may not be getting as much attention is who's making our bacon and who's packing our pork chops. And this has been in the news. And again, if you're tracking the prevalence rates, you go, oh, here's a weird little county in Iowa. What's up with that? Boom, it's a meat packing plant. Here's a weird little place in Nebraska. Boom, there's a meat packing plant. I don't know if anybody's seen recent news stories about this, but people that pack meat are always socially disenfranchised, immigrants, people of color. The work environment together, the way they make money on pork chops or bacon or whatever they're chopping is that you got to work quick and close, and I'm right next to people, and so it's close quarters, poor people. There's a long history of bad workplace safety and this kind of pressure. The stories, as I've read stories, Washington Post has done a number of stories about life in meat processing, that there's pressure to cut. If you don't show up to work, somebody else will get your job. We don't care if you're sick. Get in there and grind the hamburger or whatever else. And there's a unpleasant threat because so many people are immigrants, and some don't have are not legally in the country. There's a tension of INS coming. Will INS show up? Will the employer threaten INS? And the average wage in my state, the great state of North Carolina, $13.64. The highest wage, I think, is in Iowa. It's $15.80. And so these are people, again, making our chicken breast, doing whatever else in horrible conditions. And again, if you look at the impact at certain pockets of meat processing, again, people of color disproportionately affected. Next slide. So here's the connection. 150 plants are in the top 25% of U.S. counties. And so if we look at, here's all the counties with high prevalence of COVID, this presence of meat processing is significant. 3,500 cases. This slide is a couple weeks old, so I'm sure that slide is older. Probably the most egregious, and I love bacon. If you had a full figure shot of me, you'd see I love bacon. And Smithfield, pork producing in South Dakota, 900 COVID cases. They kept fighting, closing down. Oh, let's keep the economy moving. We'll disinfect things. Anyway, 900 people out of 3,000 people got sick. They closed for a week. They put up minimal barriers. Literally in the staff lounge, they put up cardboard dividers at the table. Like you would make a fort with boxes, and called that safe for people to enjoy their lunch. So anyway, the state of America, please. Oh yeah, it's a number of Chinese employers. Thank you, Diana. COVID-19. So it's a really compelling story. So I've got a lot of bad news, of course, but there is a lot of bad news. And there was a story on the news 2 nights ago. A researcher, a social change activist named Heather McGhee was on television. They interviewed her, and they just talked about why public opinion in favor of the Black Lives Matter movement. The New York Times study showed in the number of middle-aged white, here I am, Americans who said, yeah, of course I support that. And she talked about George Floyd's death, but the other thing she talked about, that was hopeful and so interesting. What she said is, this is about COVID-19. What she said is COVID-19 has shaken the American dream, that for white middle-class Americans realizing they're vulnerable, realizing that we're all 2 paychecks away from being destitute, realizing that we reached out to one another in a different way, that we realized our interdependence she believes created a groundswell of support where George Floyd's death was a tipping point for people to say enough racial injustice. And I cling to that, and I have it on videotape. I keep refreshing it in my computer. I watch it several times a day, just because if that's true, if his death, and more importantly, if something good can come of the inequity of COVID, then maybe this last line is there, that maybe people of color and different ethnicities and old people and young people coming together to say no more violence, no more institutionalized racism, then maybe something good comes of this horrible time. Next slide. This is a quote from Dr. Yancey. What he talked about in the article was about social determinants, but what I think is important is all of us saying, oh, can I get with the story I want on Netflix? And oh, what a drag. I'm working at home and I'm telecommuting and whatever else. He uses the phrase privilege, that this is about privilege, and the aggregate burden of comorbidities, the pernicious effects of adverse social determinants of health, and the absence of privilege is what we all need to consider. And again, the editorial just blew me away. If you haven't seen it, it's public domain. I don't have a subscription to the Journal of the American Medical Association, but Dr. Yancey really names it for me, and something we all have to think about in terms of social determinants. Next slide. I think we're going to start to talk about caution fatigue. One of the things we thought about is new, is an update, is this tension of people are tired of being in the house, and yet it's too safe to return to some of the things we used to do. Take a minute in the chat box and tell me what you're missing. Anybody who's missing something you used to do and can't safely do, go ahead and put that in the chat box while we start to talk about caution fatigue. What are you missing? Tom, I'm going to give you a big virtual hug right there. Oh, I miss lunch too. Tanya said going to the gym. Priscilla said get those nails done, right, friends? Next slide, please. Seeing grandma. Oh, Zelda, that breaks my heart. So we've got this tension of all that we're missing. Alfonso wants a hug. Austin, I'm going to meet you at the gym when it's safe, brother. I need to get rid of these COVID-19. I'll tell you what. So we're all missing these things. Everybody missing. Shoppers are missing shop. Ditto, all the above. Tom said I miss it all. And yet, as things open back up, we see this spike in cases. And so there's this tension, and we don't have an answer. But this idea, we are all tired of cooping up, tired of being cooped up. And as things open, we expected there to be a blip. And in many places, the blip is much worse and much more serious than we expected. So, Georgia was one of the first to open. Their governor, the genius, said, let's open up. What they found is 65,000 non-Georgia cell phones to get tattoos and play, go bowling and do whatever, get mani-pedis. And so most increases when things are opening up, there was an increase in mobility, 2% increase in mobility. You go, oh, well, 2% more trips, more mobility times 100 million cell phone users. So what that means in tracking 100 million cell there's 2% more movement between May 1 and June. And we got moving. I know it's true for me. I was like, I got to get out. I'm going to kill somebody if I don't get out of this house. I wore my mask mostly. I did the healthy thing. But, and again, as states reopen, case counts increase. They're just all kinds of studies today, eight hot spots, all reopening. Texas in trouble, Arkansas in trouble, places that have opened up more. Darren, you work with, that's why, good people at PIHC. Next slide. So, what we don't know, I guess the other good news I've got, if we've got good news, is there is less risk. We now know less risk of surface contamination. Remember, in March, certainly most of April, you're afraid to touch anything. I went to a nursery to look for a tree, and I'm all masked up, and they said, you can't turn over the price tag, and every time you set your hands down, you assumed you're on something radioactive. CDC comes out and says it's probably not as contagious. I think certainly good hand sanitizing, good washing, but not as contagious in terms of surface contamination. We were saying 6 feet, 6 feet. I heard Dr. Chan say 6 feet. I think we are still thinking 6 feet. And recently, CDC's raised some question about 12 feet. And so, as we live in this crazy world, sort of figuring out how to live in the age of uncertainty that we live in. And then finally, people are saying, well, this really is about old people, and those people, we've talked in these conversations many times about parallels with early HIV days. It couldn't happen to people like me. The bottom line is, if you're breathing behind the wrong person, it's going to happen to you. Next slide. So again, there's a sense of being tired of being there. This is I think this is a Washington Post article. This was a researcher at Berkeley that just really has social scientists really looking at what we're missing, and sort of how much loneliness came into play in mid-April. We really kind of hit a wall a month in, 6 weeks in. We also started to shift to, well, you can leave out a little. In North Carolina, we called it safer at home, but instead of you must be locked down, sort of only go out minimally and be whatever else. There was a spring break phenomenon. There's a kind of spring break. We saw horrifying pictures of swimming pool parties in the Ozarks. Tom says, yes, subway stuff is nerve-wracking, absolutely. And so I saw a picture yesterday, pools in Las Vegas opening up. So there's this kind of spring break mentality. The other elephant in the room is there's some tone of, if you open up, you're in favor of small business and a particular the Republican Party and the president. And so our conversation, and I'm not saying vote for anybody. What I'm saying is this conversation about public health has become one of economics and politics. And so it's become in some ways more complicated to wear a mask or not wear a mask, or distance or not distance, because of all the factors there. Next slide, please. Again, look at Marcel added this slide. That was not my choice. I just love the dude going, oh, I'm missing my homeboys. And yes, I can relate. There you are, laying on things, saying, if I watch one more Netflix or whatever. So the change in threat has changed. And part of what, again, this researcher at Berkeley kind of talked about those developmental things, but then she also said part of what's happened is just neurology. Our bodies are so tired of being on edge that the urge to relax, the desire to relax. This third bullet is important. The brain sends information to lower the perceived threat level. So some of this is just us being silly, wanting to go out and look cute in our two-piece bathing suit at the pool. But some of this is really neurology. We've been on such a level of alert for so long, this increase in depression and stress, that once the door cracked open, and maybe our brains were even saying, please let us not be on so much. And so the fact that we haven't had enough time to practice, maybe part of what's happened, she hypothesizes, is our brains are not only saying let's relax, but we're returning to habits. That the new habits haven't been formed yet. If I had a nickel for every time I got halfway in the grocery store, and it's always halfway, I got halfway to the grocery store and thought, doggone, I've got to go back and get my mask. Even though it's in the car, that habit is still not familiar to me. And what she's saying is there's a retreat away from these new learned behaviors towards behavior that's familiar. Maybe what we're doing is just retreating to behavior that's not the new behavior. Next slide. Last thing, we want back to work. There's the whole idea that Many of us have been teleworking, many have not, but many of us have been teleworking, and this whole sort of when and how and all the others. So next slide, let's talk about that. I think what's important to start with is there's a bunch of people that haven't been home watching Netflix and on Zoom. And a shout out to people who've been there. What they'd like us to know is we've been here, driving the subway, checking out your, making your bacon at the Smithfield plant. We take risks daily for you. Have your pet groomed. There's a tension I just want to name, and it's not in any way meant to be critical, but sometimes I feel that essential workers, and I think rightly so, are feeling neglected and not tended to, and there's a little resentment that they're not home getting a paycheck to watch Zoom or YouTube, and if they were here, I think they'd say I'm exposing myself every day for you, and then people are snotty about wearing a mask or entitled or whatever else. I think there's another burden. There's a thank you, Debbie. Debbie talks about a dream of not wearing the mask. Absolutely. And the other burden I want to just name is healthcare workers who've been there. I know that some people on the call, the brave people who are still seeing patients, whether it's nurses, case managers, other people on the front line. And I think to give a shout out to people that go through that fear every single day. Thank you. Next slide. So we want to go out. We're tired. Our brains are saying, and that's the number of new cases last Sunday in the world. There were 136,000. It's the most single ever, highest single ever. So you're going to go back to work. The call comes, and your boss says, "We're opening back up." In the chat box, what comes up? If you would, if you're willing, what feelings come up as your boss calls and says, "Come on back"? What questions arise for you? How will you act for those who have not been essential workers? What feelings, what issues? Lori says it ain't safe, right? Darren's ready. Come on, Darren's ready. What questions? What emotions? Okay, Yasmin's saying, do we have PPE? Have we thought through safety? How are we going to keep people safe? Yes, absolutely. Other questions, other fears. Oh, Lord, Amy's got 1,200 people in the building that she cannot test. All 1,200. All right, Diana said I'm ready to stop that. What about PPE? Oh, PPE is safety. Your protective equipment, Marco. PPE is an abbreviation for personal protective equipment. Tom says, Tom, I'm with you on that subway, man. You got to get there, but oh my Lord, you lose your shirt on Uber. Again, somebody else with public transport, and all the questions. So yeah, how are we going to get there? Next slide, please. So, part of what we're all doing is kind of figuring out what do we know for sure? What do we know for sure? And then weigh the risks. Damon and I had a conversation about going to a party and who we're going to invite over. And there's all this negotiation. Well, I know where this one's been and I don't know where that. The bottom line is at one point, I think back, my friend Greg said early on, he knew a couple people who announced in March, early April, they were going to stay in their house until they were vaccinated. They were staying in their house until they were vaccinated. I don't think that's an option for most of us. I can't stay in my house until I'm vaccinated. I know that. I will lose my mind. And so we're all kind of figuring out, in this absence of uncertainty, cost benefit level of acceptable risk. Next slide, please. So those are the things, all those things Dr. Chan talked about. Just a reminder, those things are all still in place, Next slide. Regardless of where you live, when is it okay not to? I love Dr. Chan's low risk, high. When can I not wear my? When do I social? What crowd size is okay? Every state government is deciding. I just read this morning, said in Portland, slow down again. Portland was to move forward. They said, "Whoa, we're gonna pause for a week," and Alabama saying, "Come on down, y'all, come on down to Alabama," and so there's this sense of when to reopen, how many. Crowd size has really become a real question mark. Like every state government has, just as saying office requiring temperature check at the time clock. It's probably what ought to be in place. I'd feel better going to your place than most places I go. Next slide. The analogy that's come to my mind is about safer sex. And as you're thinking about determining level of risk, I think about the early days of serodiscordance and even now. But as we're thinking about our sexual decisions, first, do we know our status? Do we know our partner's status? And what do we know about their history? One of the things my partner decided is we're sort of entertaining on our deck where there's air, not 6 feet distance, but with people who we know have been careful. If I don't know where you've been the last 10 days, you ain't coming over to my house. And so we're kind of screening. We don't know people's COVID status, but we understand that people have been careful. Gather information and weigh the risk. Develop your standing guidelines. Sort of what am I and aren't I willing to do? Dr. Chan said he's not going to get on no airplane, which I think makes good sense. I'm not going to go to somebody's house for a party if I don't know them and don't know how many people are going to be there. I don't want to go inside anybody's house at this point, really. I don't think I want anybody in my house except my sisters. Stay abreast of other people's changes. Like my partner's talking about going somewhere to see his brother, and then that's another state, and that sort of his brother hadn't been as careful. So all the questions about that. Don't get drunk and make a bad choice. Maybe I'm just talking to myself. Maybe I'm the only one whose safer sex plan was in place. And then at 3 a.m, I made the wrong choice. Please don't chat in the chat box if you are also that person. Next slide. Last slide. Just another thought. I know I've beaten the dead horse. Yeah, here it goes. So I'm going. They want to know about sex, Larry. People are dying about bathhouses, and when are we going to talk about sex? Mask over the mouth. Anyway, last quote. And again, this is from that JAM article. Are we as a nation? So what he's saying is that it's shining a light on social determinants. Are we going to just keep doing business as normal, or will the nation finally declare that a civil society will no longer accept disproportionate suffering? I hope that's the case. With that, I'm going to be quiet. Marco says, use your condoms. And talk about sex. Talk about how we negotiate this uncertain world.
Yeah, thank you so much for that, Jim. That's an amazing wealth of information. We're going to give you another second to take care of yourself, to go to the bathroom, to get some water, maybe get a bite to eat, maybe also some time to engage the chat box. Let us know what you're thinking, how you're feeling, as well as don't forget to do that survey. Tell us, the CTech team know what trainings and things you would like to see from them. We'll see you in a second. Thank you.
This is Evan again. We'd like for you to let us know how your agency is adapting currently offering. By completing the survey, it helps us capture your agency information and include the next iteration of our state-by-state resource guide. Thank you, and we can't wait to hear from you.
Welcome back, everyone. This is Larry Scott Walker. Let me actually turn on my camera so you can see this good old lace front. So I know that many of us have questions. If you're anything like me, you and as Jim so eloquently presented just a second ago, you are getting tired of being in the house. Your cities and states are beginning to reopen, and you want to know like what can we get? What can we do? Can I re-engage outside? I have a quote here that says, "Outside hit different." When outside hits different when you're still in the midst of a global pandemic. If you agree with that, type amen in that chat box. Let us know how you feeling about outside right now. So, yes, a lot of your towns, states, jurisdictions have reopened. You will see people at the parks having different gatherings, clubs, going to restaurants and things like that. And it feels like, normal. It feels like, we're back to normal. Well, as Dr. Chen blessed us with earlier, it is still, the coronavirus is still very real. And a lot of places are actually experiencing a height of new cases and hospitalizations. And it is a must that we still practice the appropriate precautions. Take all of the precautions, making sure that we are wearing masks, making sure that we're practicing good hand health, we're washing our hands, and physically distancing as best as possible for the venue that you're in. As well as Dr. Chan also covered, knowing the level of risk for the places that you're seeking to engage, understanding that certain venues carry a different level of risk. The CTEC team the CTEC team will be circulating a one-page document that will help us to assess the level of risk of the places that we are engaging. But here's a quick overview. Larger, more densely populated spaces, places like, concerts, gyms, churches, bars, sporting events, and things like that are densely populated places, and those are high level. Those present a high level level of risk. Going inside to eat at restaurants, some of my favorite restaurants are beginning to reopen, and some of them don't have patios. Well, I will not be engaging in those places because going and eating inside of a restaurant or even going to the dentist can present a medium level of risk. Eating outside on a patio, for instance, or getting your food to go, I'm sorry, getting your food to go and doing physically distant exercise, as Dr. Chan mentioned earlier, those present lower risk and is advisable, especially for somebody like myself who is going stir crazy looking at all of these walls. And it's again, we will not mention it enough. It is important that we continue to practice all of the safety precautions and measures. All right, I heard somebody say whoop whoop just now. Sexual health updates, as there are some. And a lot of us are wondering, is it safe to play in this time? So the first thing related to sexual health is knowing the most possible so that we can keep ourselves safe. And related to COVID, we can get COVID-19 from a person who is a carrier, either asymptomatic or pre-symptomatic. When we contract COVID-19 by coming in contact with droplets within saliva, mucus, and breath. So, what do we know about COVID? We know that we don't know a lot. The COVID virus is a novel virus. It's a new virus. Thus, new information is coming out every day. So between the space of our last conversation about COVID and sex and this conversation, we found out that COVID is also found in semen as well as fecal matter or poop. We do not know though, and we can't stress it enough. We do not know that COVID can be spread during sex. We don't know that, but we do know that typically coronaviruses are not spread through sexual contact and that they're not sexually transmitted diseases. So let's talk about getting it in a little bit. Y'all want to talk about getting it in a little bit? All right. So if you are, you're dying to get it in, the your safest sex partner during this time is yourself or somebody who lives in your home who you can verify is physically distancing. Again, safest sex partner is yourself. So masturbation has no indication for, spreading the COVID virus and also has some pretty gnarly health benefits. And if you're a person who is married like myself, we know the benefits of masturbation. And the next safest partner is someone who lives in a home with you that you can verify has been also physically distancing, be that a monogamous partner or somebody that you sleep with who stays in the house with you, however you want to understand that. Understanding that in this time, we should limit close contact, including sex with anyone outside of our household. if you're going to have sex with someone outside of your household, because maybe you live by yourself, or maybe the people in your household aren't people that you would have sex with. These are some things to consider. Having as few many safe sex partners as possible that you can trust and verify are physically distancing is advised, as limiting the unknown is the best thing that we can do for our health at this time. Talk, as Jim spoke to earlier, making COVID risk conversation, make this COVID risk conversation a part of your sexual negotiation. It shouldn't just be top, bottom, verse. Do you like, being licked on your left ear? It should also include conversations about COVID, potential risk. Have you been feeling any of the symptoms? Have you been around anybody who's been living with or dealing with COVID? How do you feel right now? We should be monitoring our partners and having these conversations, just as we're having conversations about condoms, PrEP, and all of the fun, amazing things that we want to do during sex. Ask questions about exposure and symptoms, and be honest about your potential exposure and symptoms as well. Again, having close contact, including sex with a limited or small circle of people that we can trust during this time, is an effective way to prevent COVID. Take care during sex. As this loving couple in this illustration, thanks Marcilla, are illustrating for us. Yeah, like we're gonna have to approach our sex. Our sexual approach, our approach to sex is gonna have to reflect our new normal. Hey, as such, and I agree, the best sex is worry-free sex. I don't want to get it in and have this amazing experience only to leave with a whole bunch of angst. So a way to mitigate and limit some of that angst is limiting things or avoiding things that put you at risk for COVID, like kissing, which is one of my favorite things to do. Rimming or eating ass, or definitely put you in contact with fecal matter, and it's high-risk activity to engage in at this time. So if we want to have sex, worry-free sex, being sure to practice good hand health, washing before and after sex, and wearing a mask is key during this time. And I know for a lot of us, wearing a mask, even outside to go to the grocery store, is kind of daunting. It's hot, it's annoying, it's uncomfortable. But you know what else is uncomfortable? Being sick, having to go to the doctor, potentially putting your family at risk, or not knowing whether or not you're potentially putting someone at risk. So here's some things to maybe keep it hot, literally and physically, during your sexual encounter. Because just because we're trying to stay safe doesn't mean that we can't be kinky. So my first recommendation is potential some PPE role play, like the people. I think those are people because I can't really see them in their outfits, but they are wrapped up in their personal protective equipment. They are getting it in. They are loving it, and they won't leave this scenario feeling like maybe I might have got a thing. Sexting, if you're getting to know a person that you really want to engage with sexually, but like you can't verify that they've been physically distancing, but you really want to engage them, maybe sexting, letting them know of all of the things that you're gonna do once you have both been tested, once you can take the proper precautions. The next suggestion is video hookups. Maybe doing a video hookup, a video date is always cool. Meeting somebody face to face with a nice drink or something like that. And if you want to take it a little bit further to a sexual space, I would just advise that you take precaution and actually trust the people that you're transmitting these videos with, because once it's on video, it's on video. So mutual masturbation is always hot and fun and safe, and it's a thing that I would have suggested in this space even before COVID. There have been articles that show that when you mutually masturbate with a person, that it can build an affinity, that can build a connection that you may not get when you just hit it and quit it. But there are things to be noted during mutual masturbation sessions. Do not share sex toys, especially insertive toys, because we're trying to limit contact with fecal matter. Be sure to wash your toys before and after with soap and warm water for at least 20 seconds. And then after, especially if you're in a situation where you're transmitting video and you may be getting off with your partner in a small space, like over a computer, making sure that we disinfect and clean those areas so that, our materials aren't all around the space for potential contamination. So you're a person who is having sex with people who you don't know well, and you can't verify as physically distancing. These are guidelines for making sure that we keep ourselves from potentially putting others at risk. If you're a person who is single and are still meeting people in places like Jacked or Grindr and other Christian Mingle, wherever, it's important that we are monitoring ourselves for symptoms, being real about our level of exposure and the fact that we could have, hey, does the WHO or World Health Organization says not to kiss, but me and the guy that I don't know, we just kissed or we used sex toys. Okay, those are decisions and things that happened, and I hope you enjoyed them. But at the same time, it's important for us to monitor ourselves so that we are not putting others at risk. So closely monitor yourself for any of the symptoms for COVID. Consider getting tested more often. And if you haven't gotten tested, go get tested. It can be a true relief off of your mind, not knowing versus not knowing. And then also considering getting tested more often, especially if, again, you're going to be doing things not even related to sex, going to the club, taking pictures with your homies and pictures, close together, sharing drinks and like that. If we're doing these behaviors, we must take the proper precautions and making sure that we're keeping everyone safe. And then please practice precaution when engaging with people who are at high risk for becoming extremely ill from COVID. So you may not get sick from COVID. You may not even know that you have it, but your aunt might, your grandmother might. My mother is aging. My mother might. And we would never want to put anyone that we love at risk. And as well, be vigilant about face coverings, hand health, and hygiene in this period, not only for your own protection, but for the protection of the people that we love and that we interact with every day. Here's some Department of Health and Human Services guidances for people living with HIV like myself. We should take extra precaution if we're people living with advanced stage HIV or poorly controlled HIV. We should do all the hand health as well, but making sure that we're physically distancing and taking every precaution to keep ourselves safe and healthy. Our regimen should not be changed, no matter what you hear, to include Kaletra as some form of prophylaxis, because it's just not proven and that should not happen right now. We should be considering the risk versus benefit of actually having live in-person appointments right now. Consult your doctor and your care team about potentially going to telecare or limiting your appointments that require you to be in the office at this point. And if you're a person with a sustained virally suppressed viral load, maybe even considering, if you can't get a telemedicine appointment, considering maybe putting off your next appointment or working with your doctor or medical team to see if you can go to less appointments annually. Additional guidances. It is important for people who take all medications, but especially people who take antiretroviral medications for HIV, to try to keep on hand at least 30 days worth of medication on hand. A lot of medical providers, as well as health insurance providers, are allowing for patients to get 90 days. If we can get 90 days, that prevents us from having to go in to a place, especially in areas like Georgia, Florida, Arizona, and the Carolinas that are experiencing a height right now. We can take some of the load off of our medical facilities by engaging them less. If you are planning to switch your regimen, it's important to monitor this close, not just your care professionals monitoring it, but you monitoring yourself as well, to assure that you're not experiencing any adverse effects during this time. And again, we can't mention it enough. It is important that we take additional precautions to especially those of us who are living with advanced stage HIV or are poorly managed in our HIV treatment and care, to keep ourselves safe. Practical advice for people living with HIV. Now, if you know me by now, or if you've attended at least one of these conversations before, you know I am a proponent of lists. I write a list every morning, and that's the way that I keep myself focused. But as it relates to my health, I write lists of my medications, as well as my care team, as well as my emergency contacts, just in case I'm ever, God forbid, admitted to the hospital and someone needs to get in contact with me, or I need to get in contact with someone else. And as I don't remember numbers well off the top of my head, I keep those saved into my cell phone as well as written down inside of my wallet. This is especially important. If you or someone that you know and love is hospitalized during this point, especially if they're a person living with HIV, assure that your medications are not discontinued. So often that, especially during this time, a person might be admitted to a hospital and it's all about the pressing issue. This person cannot breathe. We're gonna operate on the thing that they're here for. And they might forget to, give you your ARVs, give you your high blood pressure medicines. These medicines are important. So it's important that we advocate for ourselves and our loved ones to make sure that these medicines are continued when they enter into the hospital. Especially if you're a person who receives the evolizumab infusions every 2 weeks. These infusions are extremely important and must not be discontinued under any circumstances. So if you want some support in continuing these medications, please contact the people at their patient support. The number is on the screen, and they are open from 8 to 8 each day, Monday to Friday. And with that, we come to the end of the presentation portion of our of today's event. We invite you to ask all of your questions, especially the ones that have been pressing for the last couple of months or weeks since we've been able to touch base. Ask them in the question and answer box. We will be here fielding through your questions. We love you. We care about you. We support you. And again, we're stronger together. Thank you.
Thank you so much, guys. And thank you to our amazing presenters. There has been a lot of chat in the chat box as well as the question and answer box to us and to all participants. So right now we're going to have, thank you so much, Diana. Right now we're going to have a chance for you guys to ask questions and for your questions to be answered. Thank you, Cicely. Thank you for joining, Cicely. Thank you, guys. Thank you, guys. So with our first question is for Dr. Chan. Dr. Chan, someone wanted you to differentiate the information that was previously given to us about COVID and transmission on surfaces and to talk about what we know now. So they felt like the CDC kind of backstepped a little bit on what they originally said, but they want you to clarify what is the appropriate guidance for surfaces.
Yeah, absolutely. I believe it was Jim who's talking briefly about this. The surface to surface transmission is just not as robust as we initially thought. There was this joke that the easiest way to get into a medical journal was just to swab a bunch of surfaces for COVID, run the PCR, and say how long the virus, quote unquote, remained viable. The reality is we don't know if viral fragments equals infectiousness. I think Larry gave a lot of really good advice about both, virus in semen and also virus as fecal oral spread. So I think that, that level of contamination, I would certainly be very cautious about. But if you're talking about someone, breathing on a surface, and then you go into that area and happen to touch that surface, a duration of time later, it's hard to say. Again, I think there's a lot of dependent factors, but overall, I wouldn't worry. Like, for example, if you're thinking of just staying in an Airbnb, and no one's been in that area for like 3-4 hours, I think your overall risk of contracting COVID would be pretty low. I think the scenario that you should be worried about is if someone sneezes on a surface and then you didn't know about it. And then like pretty shortly after that, you come by, you engage with that surface with your hand, and then you directly touch your, your vulnerable mucosa, be it your eyeball, your nose, or your mouth. I think that's kind of the scenario in which we do see surface transmission. But, the CDC guidance in general is that the contaminated surfaces aren't necessarily as infectious as we think in the context of droplets. And I think Larry brings up a critical point, that with sex toys and other things like that, I think all bets are off. Like, I wouldn't group those in the same category. Hopefully that clears up a little bit. I could go on forever, but I'm trying to keep it focused.
Thank you so much. To that end about sex toys, there was a question about sex toy cleaners aimed at, someone said a lot of sex toy cleaners are aimed at cleaning bacteria, but not viruses. Are there any recommendations for keeping things as clean as possible if we were concerned about viral transmission of COVID and other viruses? I know there's one sex toy cleaner called Lilo that also has antiviral and antifungal agents in it, and it's only about $9.99. So I do know that there's that. Larry, is there any other information or recommendations?
I would definitely have to defer to the medical science person on the call for that. I just use soap and water, honestly, but please tell me if I'm doing something wrong.
No, that sounds good to me. If it works for your hands, I mean, I think it should certainly work for a sex toy. So I think that's great guidance, Larry.
Okay, guys. Is there any free or reliable antibody test, Dr. Chan? We kind of talked a little bit briefly in the chat box about it, but do you want to talk about free, reliable antibody tests?
Sure. There were, I apologize. There's like 15, and the FDA website updates all the time. The one that I have definitively seen the data for was the Abbott antibody test, and that one looked really good. Some of my colleagues have said that the Roche, ROCHE antibody test, I think it's like the Electrosys system, that one also looked really good. But, I don't remember the other platforms that are doing it. I apologize. I'm trying not to have any commercial bias here. Essentially what I would do is I would get the test. I mean, generally most hospitals are using a pretty reputable test. Quest Diagnostic, I think, is paired with Roche. And so, most of the big labs are going to be using one of these safer, verified antibody tests. So I would consider them to be pretty reliable at this point if they're going through a big commercial company. In terms of availability, I think that depends too much on where you are. All I can really comment on is Fulton and DeKalb. And, we have it to some degree, but it's very limited. Like, if you don't get in at the right time, you can't get it.
We have another question. How is China so controlled with no new cases? Could this really be possible?
I'll take a stab at it. That's just a really, really hard question to answer. I think there's a couple factors. I mean, one is that they just have tools at their disposal that we wouldn't want to have, or we wouldn't want to in the United States. I haven't been tracking the China data as closely as I should have. I've really been focused on Georgia and Texas, mostly in the United States. Essentially, there's always the question, like, I've seen some intelligence, I've read in the news that there are some intelligence officials who do question the case count, but I don't have any more information other than that. I will say that parts of China, it's a gigantic country, but those parts that are entering the summer months would be kind of feeling a similar lull, that we are. And ultimately, the data that comes out of the country is entirely dependent on the government. And so I can point to Brazil and say, Bolsonaro, who's their, I think it's president or prime minister, he essentially has said we're not reporting cases anymore. And so if that's the case, then the data is completely unreliable. I can't say how reliable the Chinese data is. I just don't have any additional insight into that.
If I could, I don't have the answer either, Austin, but I do think there's this element of where a government can exert more social control. There have been a number of stories where governments can say, look, it's not if you feel like it or not. And so I think the sort of downside of democracy and the downside of a participatory democracy may be that while the government has said that every time the government, we've seen armed AK-7 people showing up at state capitol saying, "You can't tell me what to do." And so there's this sort of edge of personal freedom here that doesn't exist in other countries. I think nobody's going to go on a limb and say we trust China's data, but I do think they're getting the epidemic under control is related to the fact that as a government, as a country, they give a lot less if you feel like it than we're used to. I think that's safe to say, don't you, Austin?
Absolutely.
Oh, absolutely, Jim. Yeah, don't, the authoritarian government with military deployment of police, can be very, very strict there. Although I guess I don't want to comment too much on here, but,
Absolutely. Okay. How are public gyms enforced with 6 feet social distancing? Who monitors this? 50% capacity, full capacity, etc.
I'll take a stab. What's going on? What's about to happen in my gym is you'll sign up for an appointment, and so they're getting ready to gear up. No one will ever walk in. In the next wave of opening, we're not there yet. The next wave of opening, it's as they're doing in restaurants. It's X capacity. So figure the capacity, masks being required. But my gym, in a way that we sign up for certain classes, you'll be signing up for a time slot. You can only come the swimming pool at another health club in my town. You sign up for a time. So many people can swim. You have a reservation for a block of time. And I suspect that model, of forced distancing, mask use, and massive cleaning of equipment in between and by participants is probably the way health clubs are going to reopen. But again, with some uncertainty. Again, risk. Several of you said, what are you missing? We're missing going to the gym. I'm right there. I don't know when I'll go. I know I'm going to wait till there aren't many people there, and I know they're cleaning it well. But yeah, it's a gray area. But those are the rules. And again, I think they mimic the way we've done restaurants, the way we're doing nail salons. I mean, it's just a sort of limit capacity, use protective equipment, sanitize deeply. So that's probably the model for gyms that aren't open yet.
Thank you. Any recommendation for people living with HIV who are in need of COVID testing? Do we have to disclose our HIV status, or what recommendations would you guys give?
I would say no. This is Larry. You should not have to disclose your HIV status to get a COVID test. And as a lot of people living with HIVs, or some people living with HIV, or at least in Georgia, have Medicare or Medicaid, you can get tested almost anywhere. So yeah, I don't think that you should have to disclose that information. Dr. Chan, what do you say?
I'll jump in. If you're any place where they are rationing testing or limiting testing, if anyone said, I have had possible exposure, you move to the top of the list, and there's no question. There still are places where decisions about testing are being made if you've had an exposure. The language is, I think I've had a possible exposure.
Yeah, you definitely don't have to disclose your status to get tested.
Is it better to get a rapid test or go to a lab?
I guess I'll try to take a stab at that one. That's a very tough question. I'm not, because unfortunately, it's just an issue of specifics. Like, I'm not sure what rapid test refers to. In general, I would say there are there's data to show that there are self-administered tests, but from what I've seen, those are all being, at least in Georgia, those are all being administered at the actual site. So essentially, what the self-testing protocol looks like is you drive to the drive-through, they hand you the swab, you swab yourself to the middle of your nose, and then you hand the swab back to the person, or you place it directly into the test kit. I am not aware of an at-home rapid test. I would have to investigate that more. It's rapidly evolving space. Everything I say may be outdated in 2 weeks, as I've said before. I don't know, Jim or Larry, if you have any other insight on that.
I don't.
No, sir.
Thank you. How do we know which version of the test they're using, though? How would one know what version of the test that they're using?
This is Larry. Outside of asking, I wouldn't know how you could just tell. But I'm sure if you ask it while you're getting tested, they should know.
I agree with Larry. I would just ask. That's the best way to find out. And then if they don't know, I would say, can you find out?
I'm seeing a half mask syndrome. Mask are over mouth, but not nose. People saying that they can't breathe with the mask. And what is the idea? We are breathing in carbon dioxide over time. Is this true?
Is that we're breathing carbon dioxide over time true when we have on a mask?
Yeah.
Is that the question?
Yeah.
I wouldn't believe so, Dr. Chan.
Yeah, I would say, I know that the masks can be uncomfortable. Unfortunately, I've had to wear masks for an extended period of time. I mean, in terms of overall, does it affect gas exchange? I guess to a small degree, but we haven't really seen any strong data or any studies to imply that, prolonged mask wearing can overall have like any kind of deleterious health effects. I mean, I think, obviously the higher the filtration grade on the mask, generally the higher it is to breathe through. But overall, I think it's a net benefit. If it makes you really uncomfortable, certainly build in time to have a break. You know what I mean? I think that's totally fair for everybody. But, I have not seen any particular data or study to say like, mask wearing leads to, prolonged hypoxia or leads to metabolic derangement. I have not encountered that data myself.
But I think as we're teaching, it's appropriate to say they are hot. They are hot, and respiration is different with a mask. Used the term earlier, sort of cost and benefit. Like, is the cost of you're hot and breathe the benefit of not getting COVID-19? Again, as we make decisions, they do change in the same way. Back to the analogy that condoms change the way sex feels. Having a mask changes the experience of going to the grocery store. I'm going to do it because I don't want to die from COVID-19.
Right. I thought you were going to say having on a mask changes how life feels. It really does. It really does change how outside feels as your face does get sweaty. But like you said, I'm going to wear it because I don't want to get COVID. So.
Is there any more information for people living with HIV and COVID? Is our chances of contracting COVID higher?
I'll just do a quick spiel and then turn it over. I haven't seen any new data. We had presented a case series out of Spain, with some people who had contracted HIV, who had some severe presentations of COVID. But overall, and of course, there's some good data from Wuhan to suggest that there is no increased mortality with HIV. Again, if you're less than 200 with severe immunocompromise, I would be just very, very careful about that. I would take extra caution. I think that's a category of folks where, I think extra caution is warranted. But in general, I would say we have not seen that data yet.
Yeah, similar. I've not seen anything that would indicate that people living with HIV are at greater risk or anything like that.
Okay, so we're 5 minutes over, guys, and we have a few questions, but a lot of the questions are asking, are we going to be, can you guys share the information that was shared here today? Absolutely. The recording will be made available Tuesday, June 16th, and please feel free to share it. All other information will be given out on June 16th as well. We also will be sending out a vocabulary sheet, a COVID vocabulary sheet. Thanks to Yale, we've organized and we've curated some commonly used terms to kind of help you better understand this whole COVID pandemic, because there are a lot of words that you guys heard on the call today. Jen said, has there been any follow-up on the concept that COVID might have been transferred through semen? Before we go, I did want to get to that question. Any follow-up around COVID being transferred through semen?
As far as I know, in our research for this presentation, there has not been any known cases or any new information about COVID being like sexually transmitted through semen or vaginal fluid.
Yeah, and I would echo what Larry said. You know, it, as he mentioned before, it certainly has been detected in semen. I think it's a really challenging. You know, it's hard to purely attribute COVID transmission to semen alone because, you know, generally during sex you have a lot of face-to-face contact, you know, anyway, so it's hard to distinguish, was it droplet transmission or was it semen transmission? So I don't know how to, I don't have any answer to that specific question. I haven't seen any data for that.
And guys, we're going to go ahead and give you guys your day back. And if you have any questions, comments, and or concerns following this presentation, feel free to email us at Georgia, GAETC at msm.edu. Again, thank you to the participants. Thank you to their technologies. Thank you to the staff. Thank you to the presenters. Guys, it was great. I hope you all have a safe and prosperous weekend. We look forward to you guys participating in our surveys. And look forward to you guys joining the call, our next call. Thank you all again, and we look forward to you guys joining us. Bye.
Take care, everyone. Bye-bye.
So